Good evening, everybody, and welcome you all to the monthly case discussion series hosted by Karnataka Spice Root chapter. So today we will be discussing about a pediatric case. We have our presenter for today, Dr. Krishna, who is a second year family medicine PG from Bangalore Baptist Hospital. And we have a moderator, Dr. Sebe, a pediatrician from CMC Vellore. He is done his diploma in child health from CMC Vellore and is also he's worked at Christian Missionary Hospitals, and he is also listed as one of the fellow, the Lancet Citizens Commission on Reimagining India's Health System. So his special interest is health equity, universal health coverage, and public health aspect of child health. I welcome Dr. Sabine for the session. And a few of the housekeeping announcements for the participants. I request everybody to keep yourself on mute. And if you have any queries, you can post it in the chat box and it will be addressed. And I request everybody to join with their real name or not the mobile, names or any other dependents, then you will be removed from the meeting. Yeah, thank you everyone. We'll be starting the session. Krishna, you can start your presentation and start presenting the case.
Can I start now?
Yes, you can start.
Good evening, everyone. Presenting the case of Master K, 5 month, 14 days old, male child, hailing from Tumbakada, Javadi Hills. Date of admission 5/4/2024. Date of examination 7/4/2024. Informant is mother, educated till 4th standard, and reliable. Chief complaint: child is looking pale since 3 months and abdominal distension for 1 month. History of presenting illness: child was apparently normal 1 month back when his mother noticed that child is looking pale, and paleness was progressively increasing and has become more prominent since last 1 week and is also associated with reduced activity. She also gives history of abdominal distension since 1 month, which was insidious in onset and gradually progressive in size. She also complains that her child is not gaining weight and is looking small as compared to children of the same age. There was no history of any suppressed cycle, forehead sweating, no history of any fever, no history of any evening rise of temperature, chronic cough, no history of loose stools, passage of worms in stools or bulky or oily stools, no history of yellowish discoloration of eyes and body, no history of swelling of legs, puffiness of eye, reduced or increased urine output, no history of recurrent infections in the past.
Krishna, can you hear?
Yes, sir. Yes, sir.
Yeah. So I think it may be good if you can just enumerate. You have taken an extensive negative history, so maybe it will be good if you can just enumerate the reason why you have given. So in the previous slide, you had mentioned quite a few points. So
Yes,
can
sir.
you just enumerate why you have taken each of those things?
Yes, sir. No history of sacral cycle and forehead sweating to rule out any cardiac failure or any other congenital cardiac diseases.
Carry on.
No history of fever to rule out any infectious causes of anemia like malaria and also tuberculosis. An evening rise of temperature and chronic cough also to rule out tuberculosis. And loose stools has asked to rule out any malabsorption syndrome that can be the cause of this anemia and also growth retardation. And passage of worms in stools also to rule out iron deficiency anemia due to worm infestation. Bulky and oily stools also to rule out malabsorption syndromes.
Right?
Yellowish discoloration.
Anything specific you have in mind when you're thinking of oily or bulky stools? Okay, we'll come back to it. Sorry. Okay, somebody has mentioned steatorrhea. Okay, so you're trying to say that there's steatorrhea because of what reason? What could be causing the steatorrhea? What could be the reason for the steatorrhea? Pancreatic etiology. Okay, so any particular condition that you know that causes a pancreatic insufficiency in childhood? Malabsorption syndrome, somebody has mentioned. Any multi-systemic illnesses that you know of that causes pancreatic insufficiency?
Cystic fibrosis.
Yeah, so cystic fibrosis can cause pancreatic insufficiency. So those children may have oily stools or bulky stools. Okay, so you mentioned about, okay, you can enumerate the causes for other points as well.
Yellowish discoloration, jaundice can be, and since it's an anemia, in hemolytic anemias, the child can have jaundice also. And also, I
Okay.
wanted to rule out any chronic liver diseases that can be the cause of anemia due to chronic inflammations.
Okay.
Swelling of legs, puffiness of eye, and reduced or increased urine output to rule out chronic kidney disease. That can be the cause of anemia and this malnutrition.
Is it chronic kidney disease or will it be something else before chronic kidney disease? Anybody else would like to mention why she has taken this history of puffiness of, yeah, so you will be thinking more in terms of, because you had already mentioned in your presenting complaint, right? That there is pallor. So, and you also examine this child eventually. Okay, somebody has mentioned nephrotic syndrome, but nephrotic syndrome onset in a 5-month-old child possible but rare. So, I mean, you've taken a very good extensive history. Just a few comments is that probably it would have been better to start off, I mean, in the negative history to mention the reduced urine output, puffiness of eyes, etc. before we go to the success cycle, forehead sweating, etc. And the other thing is the chronic cough is not the usual manifestation of tuberculosis in infancy. It will be usually failure to thrive. Probably you can mention regarding the close contact tuberculosis. And one more thing that I would like to mention is that usually in infants and in children, chills is a subjective feel. So it may not be possible to elicit that history of fever with chills. Maybe you can mention the history of fever, and even
Okay,
rigors
sir.
also may not be commonly seen in infants. And
Yes, sir.
you don't often see passage of worms in stools in a 5-month-old infant. Maybe it was, but I understand since it's an anemia presentation, you wanted to cover all the other etiology. So that could be the other reason, I suppose. So
Okay.
yeah, you can go on to the next slide.
The video, the audio is not clear. There are some interruption.
Mine or
No, some background sound
Krishna,
is coming.
Krishna, you're the co-host. If you could just mute.
yeah, I think the source is muted now. Yeah, you continue. Now audio is clear, right?
Yes, sir.
Yeah,
No
continue.
history of recurrent infections in the past.
Okay.
I asked this history to rule out other like involvement of other cell lineages. since it's an anemia, I wanted to rule out other cell lineages are not involved. And also, no history of suggestive skin bleeds, blood in vomitus, blood in stools, black tarry stools, gum bleed, nose bleed, or any other bleeding manifestation. This also I asked to rule out the other cell lineage, that is any bleeding manifestations are there.
Yeah, so you can specifically say recurrent infections. You wanted to see if there is any white blood cell count involvement, and
Yes,
these other mucosal bleeds, etc., for platelet involvement. Okay,
platelet
sure.
involvement. No history of seizure or weakness of any limbs. I have mainly
Okay,
asked to rule out sickle cell crisis.
okay. So sickle cell crisis again. Usually the age of presentation will be different, but anyway, it's a comprehensive history taking. So you can mention. I mean, if you're able, you will have to know the age of onset. So when you're presenting it, that is something that could be asked to you. Okay, carry on.
Okay. Antenatal history. Mother's obstetric score is para 2, living 2. There was no history of recurrent abortion, and it was a spontaneous conception. First trimester pregnancy was confirmed by urine pregnancy test after 1 month of missing period. And she was a registered case in KLU PLC. Regular antenatal visits were done and folic acid was taken. There was no history of fever with rashes, excessive vomiting, burning micturition, bleeding PV. No history of any drug intake or radiation exposure. Second trimester, regular antenatal visits were done. Iron, folic acid, and calcium tablets were taken regularly. 2 doses of TT was taken, and quickening was felt at 5th month. All antenatal scans were done were said to be normal. There was no history of any gestational hypertension, gestational diabetes mellitus, no history of any bleeding PV or leaking PV. Third trimester, regular antenatal visits were done. Iron, folic acid, and calcium tablets were continued. Fetal movements were perceived well. There was no history of gestational hypertension, gestational diabetes mellitus, no history of any bleeding or leaking PV. There was no history of any blood transfusions or iron injections during the antenatal period. Total weight gain in pregnancy was 10 kg. Birth and postnatal history. It was a term, normal vaginal delivery at KLU THC. Baby cried immediately after birth and birth weight was 2.3 kg. Direct breastfeeding was initiated within 1 hour of birth and baby passed meconium and urine within 24 hours. There was no history of any respiratory distress, neonatal seizures or neonatal jaundice. And there was history that mother received 4 doses of iron sucrose injection postpartum in view of anemia.
Okay, Amaran has asked a question. He has asked if we can mention if the antenatal history is insignificant or uneventful. I think it's really dependent on the examiner. Some examiners may expect you to enumerate everything in detail and say everything. So probably it is all right to mention it while you are summarizing, especially for a short of time. But definitely, it's to be on the safe side. Better to take all the history that she has gone through trimester wise now, and then specifically if you are noticing anything, you can mention it. But then again, I think it is quite dependent from examiner to examiner. So yeah, you can summarize, but be aware of all the details.
Okay, sir. Can I go on to developmental history, sir?
Yes, carry on.
Developmental history. Gross motor, only partial neck holding is there. Fine motor, bidextrous speech achieved at 4 months. Language, the child laughed loudly since 4th month. And social smile present since 3 months. And also the child recognizes the mother from 4th month. And child is able to follow light in all direction and child responds to sound as well.
So you can mention at the end of your developmental history, you can mention that there is a delay here. So obviously you have picked up that there is a delay in the gross motor domain.
There is a gross motor developmental delay is present.
Yeah. So why do you think there is a gross motor development delay? Others can also answer. Krishna has already worked up this child. Others can also answer. Why do you think there is a gross motor developmental delay in this child who is 5.5 months old but still does not have neck control? Any
Maybe
reason?
due to Severe malnourishment also, the child can have gross motor delay.
Yeah. So any chronic, yeah. So yes, correct. Somebody has mentioned saying that neck folding should have been attained in 2 months. So this baby is 5.5 months and has not yet attained neck folding because there's a chronic illness that is going on, which we'll be coming to in the next few slides. So main thing to remember is that whenever there's a chronic disease, there will be some amount of motor developmental delay, and this is something that you have to elucidate when you're taking history for a child who has a chronic illness. Very important to elucidate the history that there is a development delay, especially in the motor domain. Yeah. Okay.
Immunization history. The child has received birth dose vaccine and vaccination at 6 weeks according to national immunization schedule. Not received the vaccination at 10 weeks and 14 weeks yet. So child is partially immunized.
Here again, because it's something very basic, there is a potential question that can come. So again, somebody other than Krishna can probably answer this. In pediatrics, always nutrition, immunization, development are my basic questions from these domains. So can somebody tell me what are the vaccines that are usually given at 10 weeks according to the national immunization schedule?
PV, Pentavac.
No, not you, because you have already answered. I was wondering if anybody else can answer. Okay, Pentavac, that's correct. Anything else? Okay, BCG OPV at birth, that is right. Pentavalent, everybody has said. What else at 10 weeks? 10 weeks, something else is also there. Rota is there. PCV, yeah, correct. So PCV is there. PCV is actually a big game changer because post PCV vaccination introduction, lot of pneumonia and meningitis has come down. It has significantly helped in reducing the morbidity and mortality in the pediatric age group, the under 2 age group. So PCV is something that you have to stay. So immunization schedule again, just utilizing this point to stress on it that when you are presenting, especially when you're presenting a pediatric patient, immunization schedule is a potential area of being asked questions. So please know both the national immunization schedule as well as the IAP schedule. The IAP schedule contains some optional vaccines that are not there in the national immunization schedule. So you need to know both the schedules properly. Okay.
Can I go on to next slide, sir?
Yes.
Diet history. The breastfeeding was initiated within 1 hour of birth and child is exclusively
Okay, sorry.
breastfed.
One more thing. Actually, IPV was not mentioned. I think Core had mentioned PCV, Rota, and Penta. So yeah, FIPV, I think one person had mentioned. So the slight difference in the IAP and the NIA schedule is that in IAP, the injectable polio vaccine is given as IM. It's a 0.5 ml. It's given at 6, 10, and 14 in the primary series. And in the NIS, National Immunity Schedule, it's given as 6 and 14. And then recently, one booster dose also has been, recently, one more dose, third dose has been introduced at 9 months along with the MR vaccine in the National Immunity Schedule. So that is one. So somebody had mentioned in the comment box about FIPV. So fractionated IPV is what is given in the government sector, whereas in the private sector, the IAP, it is IPV. Okay. Continue.
Diet history. Breastfeeding initiated within 1 hour of birth and child is exclusively breastfed till 5 months. Breastfeeds about 3 to 4 times during daytime for about 10 to 15 minutes and 2 to 3 times during nighttime.
Okay, so here, since it's a 5.5-month-old infant, history taking has been in the diet part pretty straightforward. It is mostly the breastfeeding part and how many times during daytime, nighttime. But if it is an older child, then you are expected to take a detailed history and 24-hour diet record with the calorie deficit and the protein deficit also. So just utilizing this point again to mention that potential question from here can be about BFHI. So anybody wants to mention what is BFHI? BFHI? Waiting in the chat box. Yes, that's correct. Baby friendly hospital initiative. So there are 10 steps. So please go through these 10 steps, especially as a family physician, you're expected to know the entire concept of BFHA and how we can make exclusive breastfeeding for the first 6 months feasible for the family. All right. Okay. Yeah, continue.
Past history, there was no history of any blood transfusion in the past, and there was no history of any hospital admissions in the past. Family history, he is second born out of a non-consanguineous marriage, and there was no history of any anemia, jaundice in the family, no history of any blood transfusion or abdominal surgeries in the family, no history of any early neonatal or unexplained child death in the family, no history of any chronic liver diseases, heart diseases, kidney disease, or tuberculosis in the family. Socioeconomic history, they live in a kacha house which has only one room, and there are four members in that house. They have a bathroom outside the house and water resources from tap water. Father is illiterate and is a daily wage worker and works for about 20 to 25 days in a month and then earns about 300 rupees per day. Mother had studied till 4th standard and she is a housewife. Monthly income is about rupees 6,000 per month, and they belong to a lower socioeconomic class according to modified Kuppaswamy socioeconomic scale.
Krishna, can I go back to the previous slide for a second? Yeah. So yesterday I was talking to this family and I came across something else. So which I think they had not mentioned initially. So did you happen to get the detailed history from the family regarding anything in the past? Were you able to elicit?
So,
So actually, this 5.5 month old infant's father, he was he uh, he was married previously to another lady, and that lady had passed away. And there is a 19-year-old daughter who was born in that marriage as well. So that makes your pedigree chart a bit more complicated. So
okay.
so you may need to go back and uh, read up on how to draw that also.
Okay.
So just uh, add one more thing here. So you had mentioned about unexplained child death in the family, early neonatal death. So what's the significance of that?
Uh, that may be due to any undiagnosed illness, hereditary illness, and anything like that. So,
Yeah, inborn errors metabolism is a possible
inborn,
answer. Correct. That's correct.
and
So
also
yeah,
thalassemia child,
yeah, thalassemia, probably
similar
thalassemia child who was not taken for treatment, undiagnosed, could have passed away. That is also another possibility. So whenever you're mentioning, and you had mentioned in your history so far regarding failure to gain weight, abdominal distension. So even in inborn errors, and you had mentioned regarding gross developmental delay also. So all these things can be seen in IEM as well, right? Failure to thrive, hepatosplenomegaly, development delay. So all these are features which can be seen in IEM as well. So that again will be uh, making it relevant here. Yeah, carry on.
should I repeat the socioeconomic history?
No need, no need.
Summary: 5 months, 14 days old male child, second born to a non-consanguineous couple belonging to a lower socioeconomic class and hailing from Javadi Hills, with gross motor developmental delay and was partially immunized, presented with pallor and abdominal distension since 1 month and growth retardation.
Okay. Anybody else would like to ask any further questions, or is everything clear? So Krishna, would you like to give a bit of context since you've been here for a while? You may know a little bit about the context of where this family is coming from. So I think as a family medicine PG, that's also something that you need to highlight. Can you briefly highlight what is the contextual history of this child and family?
They belong to a lower socioeconomic class, and also they are from a tribal area mainly.
One second, I'm not able to see this question. Low birth weight in summary. Okay, low birth weight in summary. Not really. Okay, you can mention, I suppose, you can mention that child was born with weight of 2.3 kg, but it is not extremely low. So I wouldn't penalize for not mentioning that in the summary, but I suppose you can mention some. Yeah, continue. Just
They are coming from a poor socioeconomic class, and also both the mother and father are illiterate,
okay. Anything else?
and also they come from a tribal hilly area also.
Okay. So, what is the significance of them coming from a tribal hilly area? Anybody else can also
They are
on
prone for hemoglobinopathies.
for hemoglobinopathies. Yeah. What about the there is a clue for you in the chat. So this patient, you mentioned correctly that the patient is from, okay, I think everybody is thinking from a very biomedical concept. I can say thyroid disorder, malaria, etc. Yeah, malaria is something that you may see in tribal populations, but like Dr. Vidya has correctly pointed out in the chat box, when you are coming from a hilly terrain, there is access to health itself is so difficult, right? The nearest PHC may be so far away. If the child has to go for transfusions, it may be so far away. Yeah, I think Alicia has mentioned regarding malnutrition. So, how far is the nearest Anganwadi? And if they are, if the child is requiring transfusion every 3 weeks or 4 weeks, where can the child go for transfusion? So, all these things you need to know as family physician or any other treating doctor also. You need to know that this is the background that they're coming from, and they may need financial aids and they may need multiple explanations regarding you correctly mentioned regarding the parents uh, education level being low. You may need to explain to them, counsel them multiple times regarding what the child's illness is. Okay, so we'll carry on to the examination.
General examination. Child was alert, irritable, but consolable. Child is ill-built and poorly nourished. Pallor was present. There was no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals pulse rate 100 per minute, regular in rhythm, normal volume and character, no radial or radiofemoral delay. Respiratory rate was 50 per minute, BP 90-60 millimeter mercury, measured in right upper arm in supine position. Capillary refill time was less than 3 seconds. Peripheries were warm and distal pulses were felt. Temperature 98.6 degree Fahrenheit, SpO2 99% under room air. Head to toe
So
exam.
Krishna had mentioned, I think, in the first slide in examination. Can you just go back 2 slides? The first line is about the child's sensorium or the predisposition. So how is this significant here? How is it significant? Would anybody else like to answer? Why has this been highlighted? Why is this significant? Okay, Krishna, I think you can go ahead if nobody else is answering. What is the significance of your first slide?
Hello.
Yes. What's the significance of the first point that you mentioned? Emergency, okay. Appearance. You can see somebody saying appearance. dehydration, etc. Okay, so all these things may be right. Yeah, emergency. Once the child is coming to the emergency, the child is looking very drowsy, etc. Then you have to, okay, SAM is a possibility. The child is apathetic, then that's a possibility that you look at. But anemia in itself causes a lot of irritability. So that could be the reason why this child was irritable when he saw the child. So, but what others answered are also correct. Those children, this child you mentioned that they're failure to thrive. So those children with severe acute malnutrition, whether they're apathetic or not, and if the child is drowsy again, that increases the urgency of the situation. Okay, yeah, continue.
Head-to-toe examination. Anterior fontanelle was open and at level. Frontal bossing was present. Hair, there was no hypopigmentation and it was not easily pluckable. Eyes, there was no conjunctival cirrhosis, corneal ulcers. Tears were present. Pallor present. There was no signs of any vitamin A deficiency. Ears, normal, no ear discharge. Mouth, no angular cheilosis, no oral candidiasis, no gum bleeds. Good oral hygiene. Tongue is moist, no glossitis. Neck, no lymphadenopathy, no engorged veins. Chest, no Harrison circus, no rachitic rosary. Abdomen was
So,
distended.
yeah, I'll just pause you so that it will be a bit interactive. So, again, open to others. Any other rosaries that you're aware of other than rachitic rosary? She has mentioned here that there is no Harrison circus, no rachitic rosary. To highlight that there is no vitamin deficiency. Yeah, correct. Scorbutic rosary. Scorbutic rosary due to vitamin C deficiency is different from rachitic rosary in which way? Anybody can mention that? Clinically, yeah, correct. Painful. Anything else? One more point is there. Tenderness is present in scurvy. The other point is that usually it will be acute angulation in scorbutic rosary, whereas in rachitic rosary it is not an acute angulation. Yeah, I think it is mentioned by Musliha. Okay. Yeah, so these two are the differentiating points. Okay, continue.
Extremities, there was no edema, no bowing of legs, no knuckle hyperpigmentation. BCD scar was present over the left upper arm. Nails, there was no discoloration, no spooning of nails, no clubbing. Skin, flesh-colored, round, dome-shaped lesions were present over left upper back and lower limbs, suggestive of molluscum contagiosum. And skin turgor was normal, genitalia normal, back and spine normal. Anthropometry, the child's weight was 3.9 kg, expected weight is 7 kg, and it is below -3 standard deviation in WHO chart. Interpretation, child is underweight. The child's length
Actually, it is severely underweight.
Yes, sir, severe underweight. Child length, observed length is 58 centimeter. Expected length is 5 centimeter. And it is also falling below -3 standard deviation. And child is severely stunted. Weight for length, observed weight for length is 3.9 kg. Expected is 6 kg. And it is weight for length is also falling below -3 standard deviation in WHO chart. And interpretation is severe acute malnutrition. Head circumference 40 centimeter, expected 41 centimeter is at -2 standard deviation. It's normal head circumference.
So just a few basic questions to everybody who is part of the clinic, since anthropometry is a very important part of pediatrics. So anybody knows the name of the study from which the WHO study, what is the name of the study? Can we call SAM in less than 6 months? Yes, we can call SAM in less than 6 months. So okay, we will probably discuss that and then go to the name of the study. So Krishna, can you tell others also, anybody who can tell SAM in less than 6 months old, what are the criteria to say if it is SAM or not SAM?
Weight for height less than -3 standard deviation, bilateral bipedal edema, visible severe wasting.
Yeah, so if any of these are present, then you can call it SAM. Whereas in the children who are more than 6 months, one more criteria is that it is not there in the less than 6 months, which is that
Midapparam circumference less than 11.5 centimeter.
yes, midapparam circumference less than 11.5 centimeter, which is not there in the less than 6 month old age group. Okay, so yes, we can call SAM in less than 6 months also. And why do we stress on identifying SAM? What is the significance clinically and practice-wise? What is the significance of identifying SAM? Anybody else can also take this? Yes, I think Amarn has answered. Anybody else would like to expand on that a bit? Failure to thrive is there, definitely. But why is it so significant to identify that the child is severe acute malnutrition? Can we take expected weight as double the birth weight according to the age? Okay. Okay. So Amaran has mentioned it's around 9 to 10 times mortality risk is more than normal children. Okay. So expected weights, instead of taking is a double the birth weight according to age, it is better to plot it on the growth chart. If you don't have a growth chart, then there's a formula to calculate it. I think many of you may know. Any one of you can tell. Krishna, can you tell the weight for age formula for this age group? Or anybody else can also tell. Yeah, Veach's formula, which is for 5 month old child. Yeah, for 5 month old child, how do you calculate Veach's formula using which formula?
Age in months plus 9 divided by 2.
Yeah, so here in this child, it's 5 plus 9 divided by 2, which is what you, I think that is what you used, right, to mention the expected weight.
Yes, sir.
Yeah, so it is better to look at it that way. And also you can plot the weight also on the growth chart. I think you have plotted it. Yeah. Yeah, so that brings us to our earlier question. So what is the name of this study called? The WHO, all this data, it came from DASH study. Anybody knows? It's called the MGR study, multi-site growth reference study. And India was one of the countries in which it was conducted. So it's important for us to know. So as you can see here, she has plotted the weight for each. So in your exam, I hope growth charts will be provided, or if you please take growth charts with you and plot it and then show the Z scores, because that is very important. And you can show the other growth charts as well. Height for age, length for age. So till what age do we call it length, and after what age do we call it height?
Years length.
Yeah, correct. Till 2 years, it is called length. After that, it is called height. All right. So the next growth chart, I think, was on weight for length. Yeah. So if it is between -2 and -3, then what is it called? You have called this child to have severe acute malnutrition. If it is between -2 and -3, then what is it called?
Moderate acute malnutrition.
Moderate acute malnutrition. Okay. So in the weight for age chart, again, Z scores are there. And usually this weight for age chart will be seen previous, sorry, the slide before this was length for age, the one before that, weight for age. Can you just put up that? So in this, you can see that there is +3, +2, 0, -2, and -3 Z scores plotted. So what is the terminology for the area between +2 and -2 Z score called? It's called something. It is there in all the maternal mother and child protection cards that is given in the PHCs. So what's it called? Starts with R. So it's called the road to health chart. So if the child remains within that +2 and -2, it's called the road to health, likely to have a healthy outcome. So again, one more point that I would like to mention here is that here, because we have seen the child only once, we have plotted it in one single point. But as family physicians, I hope all of you will have a set of patients who you'll be following up regularly. And it's very important in the pediatric age group that you plot growth serially, because growth is never a static point. It's always a trend. So you plot it serially and see if the child is So if you open the mother and child protection card also, you will see that the card itself has descriptions such as good, dangerous, very dangerous. And the good, you will see that the weight is going up. The dangerous, you will see is flattening, whereas the very dangerous, you will see that it is coming down. Weight is progressively reducing sort of trend. So always ensure that when you practice, you have growth charts and you plot the weight and length serially. It will actually, this is a very simple measure that can help you to diagnose a lot of pathology. Okay. Yeah. Yeah, so head circumference again, I think we won't go into details. Everybody knows the definition of microcephaly and macrocephaly. Can somebody please put in the chat what is microcephaly? What is the cutoff?
Less than -3 standard deviation is microcephaly.
Macro?
More than 2 standard plus 2
More than plus
standard
2.
deviation.
Yeah. Okay. Sure.
Can I go to systemic
Yes.
examination, sir? Examination of abdomen. Inspection. Abdomen is distended and umbilicus at center. All quadrants move equally with respiration. There was no scars, sinuses, dilated veins, visible peristalsis. All hernial orifices were normal. External genitalia appears to be normal. Palpation. Abdomen was soft, non-tender. There was no local rise of temperature. Liver was not palpable. Spleen palpable 5 centimeter from left costal margin. And it was non-tender, smooth surface, firm in consistency, moves with respiration, and it was not palatable, not bimanually palpable, not able to insinuate fingers into the costal margins. There was no other palpable mass. Percussion, liver span is 5 centimeter. Percussion over the top space, dull not heard, no shifting dullness. Auscultation, vowel sounds heard normally, no bruit heard. Cardiovascular system examination, inspection. Shape and size of the precordia appears to be normal. There was no scars, sinuses, dilated veins, visible pulsation over the chest wall. Apical impulse not visible. Palpation, apex beat felt at the left fifth intercostal space, just lateral to the midclavicular line. Auscultation S1, S2 heard normal, no murmurs. Other systemic examination, respiratory system, bilateral air entry equal, no added sounds. CNS, no focal neurological deficits.
So here, since you're talking about a child who has got failure to thrive, anemia, and some motor developmental delay,
Yes.
yeah, even though this child are mainly focusing on the anemia and the failure to thrive part, definitely you should mention at least regarding the child's observed power. So in a 5-month-old child, you may not be able to exactly mention that power is 4 by 5 or 5 by 5, but at least you should mention that the observed power is, if the child is moving all 4 limbs, that means observed power is more than 3 by 5 in all the limbs. Similarly, you can check what is the tone, if there is any hypertonia or hypotonia. So you can mention, you can make a comment regarding the tone. You can again mention regarding whether the child was alert, was interested in surroundings or not. You can mention if there was any obvious facial no palsy, bilateral pupils are equal and reacting to light. And you can mention if the child had any dystonic movements. So it's better to at least mention a few significant points than writing no focal neurological deficit, because that also conveys to the examiner that you have spent some time in examining the child properly. And I think you had mentioned regarding the anterior fontanelle earlier as open. So ideally, we are supposed to measure the anterior fontanelle also. So you need to mention the measurement of the anterior fontanelle also. And I believe everybody knows how to measure this from. Can you just mention that, Krishna, how to measure the AF?
Diagonally, we have to measure.
Yeah, so from midpoint to midpoint. Yeah, correct.
Midpoint.
The anterior fontanelle is expected to close by what age? Yeah, I think I heard the answer. Somebody was saying you are right. I think
1.5 years.
yeah. So by 18 months, correct.
18 months.
Yes. All right. Yeah. So would you like to summarize now that you have mentioned the examination findings also?
5-month-old boy, second born out of a non-consanguineous marriage, belonging to a lower socioeconomic class and hailing from Javadi Hills, which is a hilly terrain, and who is partially immunized with gross motor developmental delay, presented with complaint of paleness of the body and abdominal distension since 1 month and growth retardation. On examination, found to have severe pallor, frontal bossing and splenomegaly, and who is underweight and severely stunted and with severe acute malnutrition. So this is a case of anemia with splenomegaly and severe acute malnutrition.
Yes, you can carry on.
My main differential diagnoses are congenital or hereditary hemolytic anemia like thalassemia, because the child is, this is a case of anemia with splenomegaly, and also the child is coming from Javadi Hills, which is a thalassemia bell. And my other differential diagnoses are nutritional anemias like iron deficiency anemia, vitamin B12 deficiency, and folic acid deficiency, and also hematological malignancies like ALL, lymphoma.
So can you say what is for and what is against each of these diagnoses? Anybody else can also mention.
Thalassemia, hemoglobinopathies, usually it will manifest during this age group, 4 months, 6 months.
Okay.
So it's a point in favor of this. And also the child is coming from a thalassemic belt area.
So why does a child with thalassemia present at this point? You mentioned at around 6 months. Why does a child with
This is the time when fetal hemoglobin will be changed to adult hemoglobin. HbF will be changed to HbA2.
correct? So just to expand on that, so normally at birth fetal hemoglobin percentage will be more. So as the fetal hemoglobin percentage starts coming down, and the transition period is almost completed by 6 months, and this time in thalassemia children, because the HbA2 is high, the HbA is less, they start to develop severe anemia, and many of them will present even with congestive cardiac failure. So yeah, I think you can just say that a child who is presenting in infancy at 6 months, like you mentioned correctly, this is the age at which we expect a child with thalassemia to manifest, and also no symptoms of other blood cell lineages being affected, right? You had mentioned that there is no recurrent infections, there is no history of any mucosal bleeds, etc. And if it was a child who was presenting with history of multiple transitions, this child you had seen at the time of diagnosis in the hospital, but often you may be seeing children who have been getting transfused over the last few months or even years. So that may also give you a clue. And you had mentioned regard this child again, because maybe it's only 5.5 months old, you may not see the typical hemolytic phases, but otherwise in many of these children who have thalassemia, you may see the typical hemolytic phases. So that may be another pointer in favor of thalassemia. So can you tell me the triad of thalassemia? What is a thalassemia major triad? Anybody else can also answer. Frontal bossing. One second. Frontal bossing is present. Yes, frontal bossing is present, but this child did not have other features of hemolytic phases such as prominent parietal eminence, depressed nasal bridge, etc. are not present. Frontal bossing was present. Correct. Yeah. So what is a thalassemia triad? Triad and thalassemia major. So usually they will have transfusion dependency and also There will be organomegaly and hemolytic phases. So these three features will be strongly suggestive of thalassemia major. So you had mentioned nutritional anemia such as iron deficiency anemia, vitamin B12 and folic acid deficiency. So how would you like to how will you differentiate, or how do you approach anemia in a child and differentiate whether it is thalassemia or iron deficiency? Thalassemia intermedia. What about thalassemia intermedia? Somebody has mentioned thalassemia intermedia. Thalassemia intermedia usually will not present this early in life. So a child presenting at 5 months of life with severe anemia, failure to thrive, you saw that the child is having severe stunting, severely underweight, severe acute malnutrition, gross motor development delay. So such sort of a severe presentation at 5 months is not seen with thalassemia intermedia. So this is okay. So yeah, Alicia has mentioned regarding knuckle hyperpigmentation, vitamin B12, iron deficiency having symptoms of pica, etc. Yes, clinically that is correct. All these features will be there. Also, the presence of splenomegaly in this patient is helping us to differentiate. Okay, lab wise, all of you will be working in secondary pyelonechios also. Okay. So lab wise, all of you will be working in hospitals with labs, and almost every lab will have a CBC facility. So lab wise, how will you be able to differentiate between anemia due to iron deficiency and anemia due to thalassemia? Iron profile is not the first thing that you may do when a child comes to hospital with anemia, and profile definitely will be useful later on. We'll go to Menser index later, but before that, more simpler things. In the CBC, what all are the indications? Okay, somebody has mentioned retic count. Based on retic count. So it's anemia approach. One way to look at is you see whether it is microcytic, normocytic, or macrocytic, and then based on the reticulocyte count. So, for example, if a child is having microcytic anemia and the child is having high reticulocyte count, what is it likely to be?
Like hemolytic anemia, like thalassemia.
Yeah, correct. And in iron deficiency anemia, it will be
Microcytic hyperchromic with reticulocyte count normal. Or
reticulocyte count will be normal or low. Most likely, it's likely to be low because the iron stores are less, right? The iron stores are depleted. So one more thing, okay, somebody has mentioned regarding the Menser index. So Menser index is useful to differentiate between thalassemia and deficiency anemia, but it's not always false proof. So the 13 cutoff to say less than 13 is thalassemia and more than 13 is deficiency anemia. Useful tool to use, but yeah, to remember that it is not always fault free. So you have to look at all the other features also to see whether it is anemia due to iron deficiency or anemia due to thalassemia. Okay. So what about RDW? Somebody has mentioned RDW. What is the difference of RDW in thalassemia and in
iron deficiency? It will be increased.
Okay. And in thalassemia? Thalassemia, it will be
normal.
Normal. So these are all features which will help you to differentiate. And other thing is many of the good labs will have a peripheral smear facility also. So it is good to discuss the peripheral smear with the pathologist who is available at the hospital, because thalassemia definitely will be able to see features of hemolysis. So
lot of target cells will be there and nucleated RBCs.
Yes, correct. And earlier, Alicia had mentioned regarding iron studies. So iron studies is something that we can do, but if you're working in probably a resource limited setting, it may not be available, but in most of the other settings, it may be available. And you may be able to show that there is deficient iron deficiency anemia, whereas in thalassemia, it may be either normal or it may be mildly increased. So why is it likely to be mildly increased?
So intermittent transfusions.
Intermittent transfusions, and also because of the hemolysis that is going on. So in thalassemia, it is hemolysis and inefficient erythropoiesis. Both are happening. So the iron may be increased because of both the hemolysis as well as because of the transitions that are happening. Okay, so since we are talking about thalassemia, just one or two basic questions regarding thalassemia. Again, open to everybody else also. Okay, Piyush has mentioned regarding basophilic stippling. Okay, again, basophilic stippling will be the blood picture will be like a microcytic picture with what type of reticulocyte count will be low or high? What do you think? Will be low or high? Will be usually low. So again, basically sibling is a useful finding in the peripheral skin. Okay. So we were talking about thalassemia. So in thalassemia, you had mentioned regarding recurrent transfusions, and recurrent transfusions can lead to iron overload, as you mentioned correctly. And what is the cutoff of serum ferritin beyond which you consider using chelation and chelation?
1,000.
Yeah, 1,000. The unit is very important. The 1,000 microgram per femtoliter. Yeah. So at least be aware of one or two common chelating agents. Desferrascamine is what we use most commonly, but I don't think in the family medicine Viva it will be asked in much greater detail, but at least we should know few details like when to start chelation, what are the common chelating agents that are available, etc. And how will you counsel a family whose child has been diagnosed to have beta thalassemia major. So, can you tell me briefly, Krishna, how do you like to counsel a family whose child has been diagnosed to have beta thalassemia major? First time this child has come to you, and you have to
First,
counsel.
first we will ask the parents about what they know about the child's condition.
Okay.
How, like, if they are not knowing the actual disease, we will explain to them why the child is having anemia
Okay.
and what is the cause of the anemia. That is, it is because of the low production of RBCs in the bone marrow.
Okay.
And their own
Is
understandable
it because
language.
of the low production of the low
No,
production alone? It's there is hemolysis as well,
because
right?
of,
It's inefficient
yeah, and
erythropoiesis
also
as well as hemolysis.
because of inefficient production of the ineffective quality of the RBCs that is produced in the bone marrow. There is hemolysis, destruction of the red blood cells that is happening in the baby's body that can lead to anemia in future also. And
Okay.
also they will require recurrent transfusions in the future.
Okay.
And what are the, we will explain what are the treatment options, further treatment options. Like if they have a sibling, we can look for matching of their HLA. And the ultimate cure is bone marrow transplant if they are willing for that.
Yeah.
And
So,
also
tell.
the need for further follow-up also will be explained.
Yeah, so like you correctly mentioned, you need to tell the family regarding the disease process, and that you need to mention that it's an ongoing process. So it's not like we have transfused this child once and the child is cured forever. It's a child who requires follow-up and further workup and specialist evaluation is needed. And two main cornerstones of therapy in management of the children with thalassemia, one will be regular transfusion and other will be deciding when to start chelation, and after starting chelation, optimizing the dosage of chelation as well as looking out for complications due to the disease as well as complications due to chelation. And then you need to also mention that the curative option is the better term than bone marrow transplantation is hematopoietic stem cell transplantation. So that is a preferred terminology. So you can say hematopoietic stem cell transplantation is something that you may need to consider after discussing with the specialist also. So, as you would have already seen, this child is actually being managed in a secondary care setting here So it is not impossible as a family physician for you to manage a child in consultation with a specialist. So we had not mentioned, I think, the ideas, concerns, and expectations of the family. So especially, I mean, every patient you need to be aware of the ideas, concerns, and expectations. Especially so in this child who is only 5 months old and has multiple problems. You already listed out anemia, splenomegaly, probably thalassemia. Child is having malnutrition, partially immunized child with development delay. So there are multiple problems for this child. So it's very important to know what are the ideas, concerns, and expectations of this family towards this child's disease and treatment. So with that, I'm going to pause for now so that there is some room for questions and discussion. Regarding luspatercept, I am not sure if it is available in India or not. So any questions?
I think most of the questions were asked in the chat box and it was addressed already, Doctor. If anybody else has any other question, you can please post in the chat group.
So while we're waiting for questions, anemia, it's very simple to classify. Most of you may already know this framework to classify it into 3 groups. Is it because of inefficient production? There is some problem with the production, or is there is ongoing hemolysis, or there is blood loss. So these 3 are the broad categories to see if there is what is the etiology of the anemia. And then, like we discussed earlier, some of the clinical features like knuckle hyperpigmentation, etc., will be helpful. And in thalassemia, fast history of transfusion. Lab-wise, you look at its microcytic anemia with low reticulocyte count or a high reticulocyte count. Similarly, for macrocytic and normocytic also, is it a low or a high reticulocyte count? So that will help in differentiating the etiology. So, for example, if you look at a child with macrocytic anemia, mostly it will be because of vitamin B12 deficiency or folate deficiency. And if you look at a child with normocytic anemia, if there's a low reticulocyte count, it may be seen in chronic disease or in renal failure. So that is one simple framework to look at the etiology. So I hope that was useful. And
yeah, I think there are no more queries.
Sukita, can I just have a quick word? Yeah.
Yeah, sure, Dr. Vidya. So we have Dr. Vidya, who is a family physician, head of family medicine department from Baptist Hospital. Yes, Dr. Vidya. You can-
Thank you, Suprita. I thank Dr. Sibin for very, very interactive and active discussion today. I think the points, whichever you gave, are very, very valuable for our residents, and big thanks to Krishna to come up with a case. Um, as such, in terms of pediatric case presentation and the pediatric case for the exam, the focus is mainly on history and approach, how we approach the child, and as well as because here it's not only the child, it's the mother and the whole family we are dealing with. So how do we approach the family and how do we take care of the family and manage the child is the key and the core concept we as the family physician should focus on. As Dr. Sebin clearly mentioned, the key point is to look at the child as a whole and take the whole history properly and come up with the DDs and then work towards the differentiation and be a part of the treatment plan. And that's what was highlighted very well by Dr. Sebin. And thank you so much for joining in today, Sebin. Thank you.
Thank you, Dr. Srividya. Thank you for that. Yeah, I'd like to thank Krishna for coming up with the interesting case, and also Dr. Sabin for moderating the session and with all the valuable inputs. Thank all the participants for actively participating and keeping the discussion interactive. Thank you. Thank you, everybody. We can end the meet. We'll be ending the meeting now.
Thank you.
Thank you, ma'am.
Good night.
Thank you,
Thank
sir.
you.